So I'm really excited today because I'm here with Peter Breadon, who's going to talk to us about recent work he did in immunisation. Now, Peter heads up the health policy at the Grattan Institute. If you haven't checked out any of their reports, you are missing out. So tell us what you learnt, Peter.
We looked at adult vaccinations. These are the vaccinations for older people, typically in their 60s, 70s and older. So COVID, flu, pneumococcal, shingles, really effective vaccines. They help keep people healthy, keep them out of hospital, even save their life. But what we found is that there are not enough older people getting these vaccines. And not only that, we're really worried that trust in vaccines may be going down, and the number of older people getting vaccines seems to be declining in some cases. But an even bigger finding when we looked into the numbers was there are some groups that are getting left way behind. So when we looked at this going into winter last year, the first time, we looked at COVID and we found that Indigenous people were a third less likely than other Australians to get their COVID vaccine. People who speak a language other than English at home were half as likely. And if they were not proficient in English, less likely again.
Wow.
So rural people, poorer people, lots of groups that would benefit even more on average from these vaccines, missing out on those vaccines.
Wow, it's almost counterintuitive. You think the people who needed the most will be getting the most. Do you have any sense of why those groups that are already disadvantaged seem to be missing out?
Well, unfortunately, we have a good health system in so many ways, but this is one of the big failings of healthcare in Australia and many similar countries, which is that the nerdy term for it, inverse care law, but the idea is that the people who need the care the most, that would benefit from the most, often are least likely to get it. And that goes for things like vaccines, but also things like other preventive healthcare, cancer screening, and so on. So look, there's lots of reasons behind it, and we've made a range of recommendations to government. They're currently working on a new vaccine strategy, so there's opportunities to improve policy, but there's lots of things to do here. The first thing is to make vaccination easier for everyone. Clearer guidance, more advertising, making sure that we continue to promote and expand the good work that's been done, expanding pharmacy vaccination, for example. But then there's these groups that tend to miss out, and there needs to be special effort for them. And so a lot of it is looking at the data and the primary health networks that manage the primary care system, finding out, okay, in my region, we've got better data now than we've ever had before. So we can really look and say by language spoken at home, by migrant background, who's missing out, and then we can proactively drive care towards those people. Tell the GP clinics who's missing out, do outreach programs. It really needs that combined effort at a system level to make vaccination easy and clear, but then at a local level to close those gaps.
Yeah, I'm really interested in thinking about all those different groups and the approach they might need. So you mentioned the inverse care law. We see that, I suppose, a similar thing in our work, which is often health literacy programs improve the literacy of the people who are most literate and don't really help people whose health literacy was poor. And that could be because, again, they might be done in English, or they might be promoted through channels that aren't actually the regular places that people who don't speak English go for information. I know you mentioned people who don't speak English at home and are more likely to not get vaccinated, and it's even true if their English skills are not great. Do you have a sense of if that is that, what drives that? Is it across everyone who doesn't speak English, or is it different in different groups, different reasons in different groups, or is that your next piece of research?
It's a really good, insightful question, and one of the most interesting findings from our work. So it's true that some groups are really low for vaccines, but what was more interesting is that pretty much every single language group, from Vietnamese, Arabic, Italian, these groups are all lower than the rest of the community if they speak those languages at home for a vaccine like flu, which is well accepted and well established. So if it's happening to pretty much every cultural group, it's probably not about the individual views of cultural groups as the main thing. It's also got to be about being a minority in the community, about minority cultural groups, facing some kind of extra barriers to getting vaccines. So, throughout the pandemic, we saw great programs, effective programs to go into those communities that really might have hesitancy or fear or misinformation, work closely with those communities and design interventions with them. But we can also see there's a broader issue here. It's not just about those individual communities. It's about probably, the cultural appropriateness, the cultural accessibility and safety of care.
Mm.
So, we need a big push to make sure that everybody gets the opportunity to get vaccinated, because it's so good for people's health.
Yeah, I'm on the record as saying prevention is better than Medicare, which I think is true. And what you're saying here is that some people are missing out because they're not getting the preventative care they need, like vaccinations. And we know that often the health of people who are in those groups, they might be experiencing health disadvantage because of poverty, but also because of rurality, but also because they don't speak English as a first language. So in fact, this is multiplying their disadvantage. And as you said, the people that most need to be vaccinated may be the people that are missing out, and not necessarily because of vaccine hesitancy. Did you get a sense that that could be the factor? More likely, it sounds to me that you think it's cultural issues around the way that we provide our healthcare.
Well, the underlying reasons will be complex. We did find that if you face many different barriers to healthcare, such as poverty and being in an area with low supply of healthcare services, and maybe being from a different cultural background, they do add up and compound intersectionality. So that is an issue. But that's why we need a health system that really kind of sheds light on these issues through the data, find out where the gaps are, and then we need to drill in, in those communities and work out the solutions. But the other thing we found is there's some big systemic problems. So it's a bit of a complex picture, but we found that the GP clinics that have, lower fees, that have more diverse patients, poorer patients in rural areas, these clinics had lower vaccination rates. So we do know that our funding model for primary care is unfair compared to the best funding models in the world. It doesn't do enough to adjust for disadvantage or even how sick people are. So there's got to be a big fix for the funding model to put the money to the clinics that have the most complex patients that might need the most explanation and support to, for example, get vaccinated. But then we need to use the data to find, once we fix that funding model, what are these local issues? And then we need to make the clinics and the primary health networks accountable for closing those gaps. But we do have a golden opportunity here, because we've never had this rich data before, where we can find out so much about people, understand what the barriers might be at a community level, and then understand whether the interventions are working, because we can measure this stuff almost in real time now.
Yeah.
So this is one example. Vaccines is kind of potentially the vanguard of putting measurement and equity and accountability for improvement at the center of how we run the health system. And it also shines a light on that bigger need to make funding fairer overall.
Yeah, look, it's just so interesting. For those of you that haven't, if anyone hasn't read this report, you need to. It's super informative. It did just create for me a lot of questions. And for us, our work is often working with those communities, or our members might be working with those communities, and some of our key stakeholders like FECA and ACOS too. So I'd love to see government thinking about funding organisations like us and others to actually have those conversations, to prove your assumptions. It is about the cultural appropriateness of care, or it is about something else, like the fact that when I grew up, this wasn't a thing and now it's a thing and no one told me, and meanwhile I moved countries twice. So getting that triangulating, if you like, with that data, people's real experiences, their real understandings, would be a terrific next step. But you mentioned a little bit, just before we finish up, you mentioned a little bit about what you want government to do. Is there anything else you want to ask them to do while we're on the subject? What else do they need to do?
Well, we've seen that, for example, there are other issues with older people's vaccination. Our rates in aged care are really disgracefully low, including compared to some other wealthy countries. And the government's done a good job by releasing those data, but we now need to set targets and close those gaps as a big priority. And the other thing is, we've probably dropped off the kind of advertising and promotion, especially since there's growing fatigue and some suspicion growing in the community potentially about vaccination following a pandemic. So a big push on informing people, simplifying the messages for what happens. But then it's really about embedding these data, setting targets for equity. We've done that for child vaccination. It's been a huge success.
Yeah.
We don't have those kind of targets for population coverage or for equity for older adults. And given the strain that hospitals are under, anything we can do to reduce those avoidable hospitalizations, great for the person, great for their family, but also great for the health system. So that's really building in that measurement, that accountability, those targets, and then just continuing to push to make vaccination easier and simpler for everyone.
Yeah, that's fantastic. So that's finished. What's what's on the agenda next? I'd be really keen to understand.
Well, we're currently working on a report about access to medical specialists. So there's your cardiologists, oncologists, dermatologists, etc. And we know that the costs for consumers have skyrocketed,
Yeah.
and the costs for governments are growing really fast. So we need to look at how we can make sure the people who need that care are getting it, because there's alarming signs that people are putting off that care too long. Wait lists are really long, or they're missing it altogether because of the cost and the long wait time. So that's our next focus.
So we hear people who go to their GP. I've had a few of these recently. The GP perhaps gets them to have some tests and says, I think you need to go to a specialist. And at that point, they've run out of cash. So I was on Talkback Radio recently, and a woman was saying that it's exactly what had happened to her. And she was now selling her clothes on eBay so she could afford the specialist appointment. I don't think anyone in Australia really thinks that's okay, right? So we do need to do a lot better, and I'd love to talk to you about that. So for those of you that are watching, do you want to hear Peter and I talk about out-of-pocket costs for specialist care? And do you want this amount, or do you want a lot more? Let us know, because we're happy to have a chat and really start a conversation about these important issues. Fantastic work that Peter and his team are doing at the Grattan Institute, and we really thank you, as I'm sure all Australians do, for doing the research and then asking the hard questions of government. So thank you.
You're very kind. Thanks very much.